हेलो सर। हेलो। Hello, can you hear me?
Yes, sir.
Um, uh, can I actually go ahead, start the session? Hello,
Yes, sir.
am I audible first of all? Audible, I am.
Yes, sir.
Uh, can I start the session? There will not be any PPT, but I'll be talking to them,
Okay, sir.
right?
Okay.
Um, Fine. I think only 15 participants are there now. How many of them are there? How many of them are there? Because I think I will not be able to see those number of participants. May you know how many are there?
अरे ईयरफोन किधर लगा है?
हाँ जी,
क्या एक्सपेरिमेंट कर रहा है?
8 people, 10 people, 15 people, 20 people. How many are there, please? Hello. Sorry, I'm asking you. Anybody can respond to me. How many participants are logged in now? In my screen, I can see some 8, 9 people. Is that only 9 people?
Hello, sir. Some participant from YouTube.
Oh, YouTube. Okay. Anyway, I'll start. Today's session is actually going to be a little different from the usual session. A very good afternoon to each one of you are logged in there from Nimans, Bangalore. And especially today is actually for those who have cleared the first stage. And now you are in the second stage. Many congratulations for you for your achievement and for your interest, first of all, actually, that because disaster management is not a very interesting session for everyone. And especially and these sort of CBR and emergencies, disasters are even particularly actually very, very odd sort of a subject. And today, again, I apologize to you for the delay in starting the session because due to some glitch, technical glitch here. And I thank Dr. Mishra for actually organizing this and his team from HBNI. And today, what are we going to do is there will not be any PowerPoint presentation, but there will be actually questions to me. So I will answer that. So let us be actually a little more interactive on the second stage. And later on, you can also shoot me some questions and we will provide you those materials also for reading later. So instead of going on lecturing, that too actually very monologuous sort of a lecture. This is actually because I am here and you people are listening. So that is actually already done once. So let me actually put you some questions. You can actually put those questions back to me. For example, in the first stage, I covered what is that psychosocial care is important in disasters, how it actually impacts somebody, what are all the factors contribute to psychosocial impact, and what are all the very basic sort of reactions, which is actually immediate reactions, long-term reactions, how these are all impacted individual level, I mean in a group, family sort of a thing, community, and what is the way to help them, and also actually that how caregivers get affected in these sort of CBRN incidents. So roughly we covered in these things in the first stage. So second stage, we will go into next level. So for this, I need some questions from you. So you want me to prompt or you can shoot me questions? Either way. You can actually put this into chat box. Then we will actually have, or somebody can even speak on the mic also, those who are there. Please, I mean, because I don't think we are a large number there. Only very few people are there, those who are in the second stage. You can ask me, actually unmute your mic and ask me, or unmute your video and ask me. So let us actually be interactive, actually, that this. Right, please go ahead. Your time starts. So in second stage, what is that actually questions you have on this area of psychosocial care in CBR and emergencies or disasters? Because see, I have been doing this online courses for right from COVID days onwards. One of the major stress for the even for the participants, students, or who are the other side of the screen, and even for the person who is actually doing this also, this is actually going to be stressful also. Always listening, hearing. So let us make it actually a little bit interactive here. That's what I'm inviting some questions on psychosocial care in CBR and emergencies. Please, either you type in the chat box or you ask me. Manoj, is that okay? I mean, people can do this? Hello? Okay. I think so far there is no questions. I'm trying to actually read. Anybody has any questions? Anybody wants to ask any questions? Okay. If there are no questions, probably you can send me those questions. You can mail to the institute. They can actually redirect that questions to me. I will answer it, and I will also give you those answers with the PowerPoint with you. See, one of the important aspect of the CBR and emergencies are disasters are other than understanding the reactions, other than understanding the psychological symptoms, what exactly actually happens or happened in previous disasters. Like I was actually sharing about 1984 Bhopal disaster and the kind of mental health issues which has been captured from the population. Definitely, actually, that these things actually can occur because see, in India, if you look at actually that 12% of our population suffers from mental health issues. That is actually normal times. This is according to National Health Mental Health Survey, which was done and coordinated by NIMANS across the states. So this came in 2016-17 time, and so 12 crore Indians suffer from some form of mental health issues. So what happens is during the disasters, these things actually gets multiplied, these numbers, because there are important three things are important. Why this population who are vulnerable? Like I told you, many of the population are vulnerable for CBR and emergencies. Everybody is vulnerable, but mostly actually who is going to be get affected most is the younger people population, the children, the elderly, the women, or some people who are actually living alone, people with disabilities. So all these people are actually going to have higher level of stress that will actually propel them into so many other ailments. See what happens in on a mental health front for the survivors are, see there are 5 Ds occurs. Disaster comes like CBR and emergencies. CBR and emergencies or incident is actually a disaster only. So what happens is disasters brings in death, destruction, injuries. CBRN means can bring in death and destruction, injuries also, a large amount of issues on the physical front. Added to that, they may not be actually able to function like before. They may lose their job, or they may not actually continue their job, or they may not go to rejoin their job because of contamination, radiation, and all those sort of things. So you lose livelihood, and you are not in touch with many usual day-to-day events which you used to do it, or with the people, or with the society, or with the community. So all these things happens. So probably you will be displaced also. You are displaced in the sense that not from one place to another place. You will be quarantined. You will be inside the hospital, like which we saw in COVID-19. So all these things, disasters brings in number of things, and that actually increases your distress. So the second D is disaster leads to distress because of your exposure, because of your experience, unpleasant experience. It is unpleasant experience. You are witnessing it. You are seeing that. So all these things are not a pleasant sort of a thing. People who are crying, wailing, falling sick, dying, injuring, all those things. So disaster leads to distress. So if this distress is there for a longer period of a time, so what happens is that distress actually leads to dysfunction, because when you are feeling distressed, for example, you are not feeling well mentally, somebody scolded you, or you lost some money. So what happens is you are not in the mood to talk to anybody, or you are getting angry, frustrated, irritated, or you lost somebody at home. So what is that? You keep aloof, you don't interact with anybody, mingle with anybody, you stopped eating, or you may be eating very less, you may not be sleeping, or you may be sleeping very less. So all these changes actually happens. So by this, then you are not doing anything, you're simply sitting. So that is where actually that dysfunction, our functionality level actually goes down. Then that functionality level actually persists for some time. What is that next level happens is the fourth level, D, is disorder. That is where actually that I was talking about little bit about depression, anxiety. So all those things actually PTSD, which I was talking very importantly, PTSD in CBR and emergencies. So these are all the diagnosable sort of conditions which needs to be actually evaluated by a professional and diagnosed, and to put on actually certain interventions, helping strategies. That is even medication, along with that certain amount of psychosocial interventions, non-pharmacological medicines, treatment. So for this PTSD, depression and all, two type of interventions goes. One is a pharmacological intervention, that you have to take some tablets, medication. Along with that, non-pharmacological interventions, that is a therapy, counseling, and all those sort of things. So both these combined actually should be given to these sort of people. That is at the fourth level. Then, if this is also actually not taken properly, adequately provided with the care and support, the last stage is actually the disability. This is not physical disability. It is actually mentally actually that they will not be functioning properly at the later stage. So these five things actually happens in any disasters. CBRN is also actually not left out. So whoever is actually in CBRN emergencies will also actually have all these five Ds. Our thing is that people who are in mental health interventions or people who are actually mental health care providers, our job is actually to arrest this. We can't actually sometimes stop disasters, prevent disasters, or because of disasters there will be distress that we can't actually prevent. So but we can actually prevent actually that, reduce the dysfunction. The third stage can be actually minimized or even actually little modified, and fourth stage also actually that we will be able to actually handle it if we handle this second stage properly. So when people are actually in the distress stage, we need to provide care and support to them so that people don't go to the fourth stage or fifth stage. Only with the distress, the next stage actually a little bit of dysfunction or something, they will be able to actually come back to their normalcy. So one of the primary objective of psychosocial care is normalizing. So we are not here medicalizing actually the things. We are not actually encouraging them to take medications, antipsychotic medications or depressive medications. So especially actually that those are required actually only for a little, very small amount of people only. Not everybody requires a medication, but everybody requires some amount of psychosocial care in form of counseling or in form of reassurance or in form of various other psychosocial care techniques, which I'll be talking about it. So that is what, and hardly actually 1 to 2% requires medication here. Who are all those actually 1 to 2% who requires psychiatric medication? Whereas rest everybody actually requires psychosocial care, and in that only 4 to 6% of the population only requires actually higher sort of a psychological care. That means therapies like cognitive behavior therapy, supportive psychotherapy. These sort of a therapies, group interventions need to be done. So only very little population only requires psychiatric medication, because these 1 to 2% of the population, either before these sort of a CBRN emergencies, they were already predisposed to some form of mental health issues, psychiatric issues, sort of a thing, before this sort of incidents. And second is that because of these sort of incidents, these sort of conditions which they were already predisposed must have actually exacerbated. They must have really actually felt it very, very stressful to actually to face or experience these sort of CBR and emergencies or disasters, because they were already vulnerable. They were already on medication or they were already on some mental health support. So these sort of incidents actually that they could not withstand, and then again actually they will go into relapse mode. So they will fall back sick or relapse. So again, actually that. Or the third issue is that people may be fine before the CBR and sort of an emergencies, but post CBR and emergencies or disasters, due to this very traumatic, unpleasant experience or loss or something, they may develop actually certain mental health conditions. So they will require actually medications. So here, my point here is that not everybody actually requires pharmacological treatment here, but everybody actually requires psychological treatment, but only the degree only varies. So not everybody requires all full protocol of psychological deal. So it depends upon, which I was talking about that day, that based on the magnitude, based on the occurrence, and your where you live, what are all the surroundings actually you are living in, how much you are affected, whether you are in the periphery or in the ground zero. So all those things, factors actually comes into play. So that is where actually that the psychological care actually comes into picture. So how long actually these needs to be done in CBR and emergencies? Of course, immediately we need to provide psychological care. That is actually, it starts with, the protocol starts with, like again, I was talking about D. Here actually, again, we will be talking about 4 or 5 Ps. So D and P, DP, we all actually understand. You need to keep that in your mind, because DP today is actually everybody understands. You don't put your DP here, everybody puts their DP. So D is D, you understood about disasters. P is psychosocial support. First and foremost is psychological first aid. So it is just as equal to as a physical first aid. How we provide in an emergency psychological, physical first aid. Psychological first aid is also equal, something like that. It is nothing very, very complicated, very, very simple. Three things actually that WHO actually gives how to provide psychological care in times of a distress, in times of a disaster or emergencies, including CBR and emergencies. So one is look. So one, I mean, immediately what you have to do is providing psychological care. You have to be present there. You have to be with the survivors. You have to be with the people who have actually, I mean, undergone, experienced, witnessed these sort of incidents. So being with them itself is actually the biggest psychological support one. Second is look at them. Third is listen to them. And fourth is look, listen, and link. So these 3 L's. So D we understood. Then the P's I'm coming. The first P actually has that 3 L's. So these 3 L's are very, very important. Added to that, you need to be with the survivors. Next, you will be actually listening. I mean, showing active listening. That's what I was talking about. L. And also, you have to show them actually the empathy. So you have to actually really understanding them, whatever the reactions, whatever the emotions they may be showing. For example, not everybody will be calm, or not everybody will be frustrated, not everybody will be agitated, not everybody will be complaining, not everybody will be criticizing. All these things which I'm talking about, some people may throw this symptoms, sometimes will throw that symptoms. They will react actually according. So every individual is unique, and the way they react to this sort of situation also will be actually very, very in their own way. So whatever this, we have to accept it and listen to them, and then only actually we'll be able to provide that psychological. So accepting them, listening to them itself is actually a very big psychological support for them. Added to that, also actually reassuring them. One of the major thing is that there will be palpable fear and anxiety among this population. So we have to reassure them. So which we already do it in our day-to-day life. As a father, we do it for our kids. As a mother, we do it for our kids or brothers. Our parents do it for. So I mean, it actually happens at different level in our day-to-day life. Oh, here also we need to actually do the same sort of a thing, reassurance. So these are all some of the very, very basic principles which I will be giving you material actually to for you to read. Psychological first aid. So this is actually immediately we provided, I mean, immediately after the incidents, maybe say actually that 72 hours, or even actually that 3 to 4 days time during this actually immediately post, I mean, incidents. So next level of care is psychosocial care. So what is the psychosocial care? You provided psychological first aid. The next is actually the psychosocial care, next level. Like how you provide physical first aid, then you actually take them into a casualty or a hospital, provide immediate sort of a dressing for their wounds and cleaning and dressing for their wounds. So those same procedure actually here also happens, but it is actually at the mind level. I mean, it is at the mental health. The different level actually. So what is that we saw 3 L's here also actually we have actually some 7 techniques, like which I told you actually that listening, active listening. There is one technique. Second is actually that empathy, putting yourself into others' place, not actually forcing others to actually to do it, but you have to actually to understand anybody, you have to put yourself into others' place. Third is actually that um, active listening, the empathy, and another is social support. So how we have to bring in actually the social support. And another one is act. I mean, you have to actually somewhere actually make them engaged. So that is actually that externalization of interest, which we call it. So I'm going to give you all those things actually in a PowerPoint. This since this lecture is very very short, I will just actually talk about some of these things, and I will be providing you with this, and so that actually that you will understand it actually much broader actually when you read those things. And also spirituality is actually one of the psychological care technique. So many people would actually wonder whether going to a temple or praying is a psychological technique. Yes, of course, it is actually a psychological technique. WHO has included in a definition of health and mental health, spirituality is actually one of the component of health. I mean, this one. So that is where actually that this is also today we include spirituality as one of the best way of actually handling stress, which buffers actually people's stress from any adversaries. So this is also actually psychosocial care. This is roughly given to people who are actually encountered these sort of a disasters, say from 72 hours to 2 weeks sort of a time. The next level is the psychological rehabilitation. And next is reconstruction and all those things are going on. So for CBRN, what is actually essentially matters is psychological care first and psychosocial care. So first aid and psychosocial care. This rehabilitation, reconstruction, and all these things are long term. For example, Fukushima or 1984 Bhopal disaster. So there people require psychological rehabilitation or psychological reconstruction of all those things. But other than that, the incident where it happens, these two actually can take care of people's mental health requirements normally. So that's where actually that these two techniques actually comes into play. And add to that, one of the important aspect is that providing specialized sort of a care to these vulnerable groups. So in that you have to prioritize actually psychosocial care to people with disabilities, children, and all these people based on actually their vulnerability, which we all know actually that age is their vulnerability, their exposure is their vulnerability, their inability to function is a vulnerability. So all these things actually combines actually and puts them into more distress. So that is where actually that we need to actually provide them with very specialized, focused, prioritize sort of a care to them. So that also I will be giving them in that this one. And add to that, how to identify and referral. Identifying referral, which already I spoke to you in the last class, and I'm sure actually that you may be having some questions. I want you to actually just mail those questions to our course coordinator or course team so that I'll be able to actually respond to you actually that identification of that reaction symptoms of the people both short term and long term, and we need to actually refer them to a proper mental health professional. I mean, trained, proper, certified sort of a mental health professionals to handle those issues actually at the tertiary level setting. Tertiary level setting means they may have to actually go to a department of psychiatry for an evaluation. If there is actually this dysfunction is actually persisting for them, then now, for example, in sometimes one may not be able to function properly. They may be actually always worried about it, always crying about it, always talking about it, and not doing anything. So there may be actually some dysfunction in their biological functions like sleep, appetite, and others. And also actually that behavioral also, people maybe started smoking more, people maybe started drinking more, or people stopped talking to others. So these sort of variations may be there. If you, I mean, if somebody finds like these sort of things, they have to identify and refer them. For identification, there are a number of tools and instruments are there which are used by even non-mental health professionals. And mental health professionals, of course, they do a very standardized sort of a tools to actually not only speak and actually get those things, but also, administering these tools and to actually understand actually that their level of stress or level of actually dysfunction, all those things are there. So finally, actually that referring them for an appropriate support and follow. Follow up is also actually very, very important. So all those things actually are very, very structured in the CBR and emergencies, and this needs to be actually required. So in many times, Western countries, there are actually very strict protocols for something like this, how to do it, what to do it, where to go, and how long one should actually take this sort of a intervention. So this also actually can be actually provided in your PPT next time when we actually come back to you. So this is what actually that roughly about psychological care next in this one. So in that, what they will do is they will identify actually that what sort of a condition they have, whether they have a depression, whether they have a anxiety or generalized anxiety disorder. So all those things are actually to be actually given, identified based on this test which they will do it. So that is important to us. So, but that is all a very little more clinical also, because it needs to be evaluated properly by a mental health professional. Even non-mental health professional also can do it, but they will not be able to do complete sort of an evaluation, but they will screen these people with these sort of reactions. How they can screen? There are different instruments are there. They need to be actually trained on that. For example, self-reporting questionnaire is there. That PHQ is there, patient health questionnaire is there. So these are all actually some of the screening tools which even a non-mental health professional can apply on people who are in distress, or to identify actually the distress. How we will know people actually who are in distress or not distress? So probably actually one of the metric is that they must have actually experienced CBR and emergencies. So in that, we have to actually apply these scales. For example, SRQ is a 20-item WHO instrument for screening. So we have to actually identify whether this person is actually having 1, 2, 3, 4 symptoms, like not sleeping properly, not eating properly, always actually feeling negative, feel like actually killing oneself, or actually, so these sort of symptoms are there. So if anybody actually fulfills around 6 to 8 sort of symptoms in that among the 20, so they need to be actually further evaluated by a specialist or a trained mental health professional. So that is how actually that is actually the other level of actually doing a screening by a non-mental health professional. So this is where actually roughly I'm putting it actually very simply, that what one can actually do at the next level of psychological care, provision of care, by identifying providing sort of a care, and also doing an assessment sort of a care. So with this actually that I will stop it. If you don't have any questions, then we can actually wind up and we will actually provide you with the materials. I request you to put me some questions, make this session actually more interactive, so that it will not be actually very monotonous or boring, because this is actually at the end of the day we are talking about mental health. We can easily relate when we are actually discussing about behaviors, thoughts, feelings, emotions. So that's where actually that I encourage you to actually please message me. So far, no one has actually messaged me here. So again, I'm expecting you. If you have any questions, you can message me. Otherwise, we will wind up. Thank you very much. Manoj, I think if there is no questions, we can wind up. Mr. Anurag. Any questions? You can actually also mail those questions to the team. we will be glad to answer those questions. You can ask about individual, you can ask about family, you can ask about community, you can ask about workplace, stress related to CBR and emergencies, anything. So thank you very much. If there are no questions, and from Manoj or Anurag, anybody is there to actually close this session, or I will close this?
Yeah, hello, sir.
Yeah. So if you, I mean, probably there's no question. So we will actually, I have asked a question. Somebody has asked a question. What is that question?
In chat box, there are, sir. Yes.
Sorry, I'm not able to see that question. Can anybody
Just
read
see.
that question? I'm not seeing, I'm not able to see.
Interventions or institution-based intervention at this stage, post-disaster?
Okay, so that's a good question. So one is immediately the acute care will be at the site only. Actually, that I mean, site means in CBR and emergencies, unlike other emergencies, you can't actually be there because that area may be contaminated. So you may be actually shifted to a safe area or a location. There you will be actually provided with basic psychological care, and the amount of then we have to evaluate what type of actually uh, level of impact you have it. Based on that, actually you may be actually shifted to institutional based, but mostly institution based care actually doesn't happen in disasters. But in CBR emergencies, it is a possibility, because if there is a chemical incident, there will be burns, or there will be some rashes, or some physical ailment will be there. Obviously, you will be actually shifted to an institution. There, the mental health, I mean, care also actually coming along as a add-on along with your basic medical support. So that is one aspect. So for a very, very separately, you are taking them to a mental health institution, but that actually doesn't happen here, because in CBR and emergencies, you will be always mostly carrying the physical impact along with you in such incidents. But of course, there are actually people also may require actually some amount of institutionalized care, which I was talking about at the fourth stage or fifth stage in the 4 5 Ds which I was talking. So the people who are actually diagnosed with a depression, or even diagnosed with some other PTSD or something, may require actually short or duration based on the level of impact on them. But mostly actually that they don't require actually that full-fledged institutionalized sort of a care for everyone. Yeah. Thank you very much for that question.
Sometimes the stresses are so much that there is a repetition in the sense the person recalls that event and gets into stress. Then how does the convergence between medical and mental health interventions, how do they converge, and how is it? Say suppose you have to give a some kind of, say, sleeping tablets or something to de-stress themselves. How do non-medical and medical converge at that time? When I say non-medical, I meant non-pharmacological, which is mental health, basically.
See, of course, pharmacological interventions will come for such situations if the person or somebody who requires that. Along with that, of course, non-pharmacological interventions are today actually that there are a number of strategies actually that one can employ, or non-pharmacological interventions will take care of it. For example, coping strategies, or stress management strategies. So, relaxing them. There are different type of relaxation methods are there. Pranayama is there, breathing exercise is there, yoga is there, or physical exercise is there, or mindfulness is today. Everybody is talking about mindfulness is there. So different strategies are there actually to actually buffer along with the medication also, because at the end of the day, medication for sleeplessness, medication is not actually the final answer. It may give you actually ad hoc sort of relief or immediate sort of a relief actually for you to actually to provide your brain actually to rest or something. But on long term, actually, that you need to actually inculcate or practice these sort of strategies, non-pharmacological strategies. So that is where actually that will be more long lasting, more healthy, and more doable also actually that on long term. So it doesn't actually come back with any baggages actually, like what you do eating a chemical and the other side. So that's where actually that, yeah, it depends upon the situation also. For example, somebody who has not slept for many days, and definitely the consequences will be actually even very, very drastic if somebody has not slept for 1 week. So one of the immediate sort of acute care is, of course, we have to actually make him sleep, put on certain medications, and then later on, actually, that we have to actually teach him on certain other non-pharmacological aspects to actually sustain that actually that. So that's where actually that here also it applies, not only CBR and emergencies, even normal days also it actually, normal times also it actually applies. Yes. Thank you. Thank you for the question.
Thank you. Thank you.
Yeah. So, okay, then if there are no questions, then we shall actually close this session.
Thank you.
So, yeah, thank you very much for the team there with Mishra sir and his team for organizing,
Yes.
and all those who are here on the second stage. Definitely, actually, that we will come back to you with more actually information or whatever the things. You can also feel free to actually mail them. Thank you very much.
We await your presentation, sir.
Yeah, we will give you.
Thank you.
Thank you so much. Manoj, can I actually log off?
Yes, sir.
Thank you.